Welcome, everyone. We will be getting started with our Grand Rounds webinar in just another minute or so. So please stay with us. Welcome to our ICAP Grand Rounds. Good morning, good afternoon, and good evening. I'm Dr. Jessica Justman. I'm the Senior Technical Director for ICAP at Columbia, and I'm very pleased today to introduce our topic and our speakers. We're going to be talking about advanced HIV disease. And we will hear more about that in a moment, and I'll tell you about our speakers. We'll have our presentation. This is just our usual reminder that we'd like you to put any questions that you might have in the Q&A box and keep that separate from the chat box. And we will have some announcements at the end about our next Grand Rounds webinar. And of course, the webinars are recorded, and the recording and the slides will be posted on the ICAP website. We're going to be talking about advanced HIV disease, which probably most of you know is the late stage of HIV when the immune system is severely weakened, and it makes the body very vulnerable to opportunistic infections. People with advanced HIV disease face a very severe risk of illness and mortality if they don't receive diagnosis and treatment in a timely fashion. So we're going to be hearing from our very own experts here at ICAP, Dr. Andrea Howard, who's the director of our clinical and laboratory unit, Dr. Suzue Saito, who's the director of our strategic information unit, Dr. Tafadzwa Zinamaraira, who's our country director for our Zambia program, and Dr. Taish Ferreira, who's the program director for our ICAP in Mozambique program. Suzue, would you please go ahead and get us started? Thank you.
Yes, thank you. Sorry. Do you see my screen?
No. No.
Okay.
Now you just want full screen.
Yep. And
then you want to swap.
Okay.
Perfect.
Right. Thank you. Good morning, good afternoon, good evening to everyone joining across different time zones to tune into our talk today on responding to advanced HIV disease, global lessons from a multi-country assessment. My name is Suzue Saito, and I'll start us off here. Here's the outline of our talk today. We will first provide an overview of advanced HIV disease, or AHD for short, including definitions, some prevalence data, and relevant WHO guidelines. Then we'll discuss the objectives and methods of the assessment we conducted and discuss the results both at the facility and patient level with special focus on Mozambique and Tanzania. And we will end with some concluding remarks. And I'll turn it over to Andrea, who will walk us through the overview of AHD services.
Great. Thanks, Suzue, and hello, everybody. It's Andrea Howard, and I'm going to just start with a definition. And probably most of our audience is aware that advanced HIV disease is defined as a CD4 cell count less than 200 or WHO stage 3 or 4 for adults, adolescents, and children 5 and older. While all children younger than 5 years of age are considered to have advanced HIV disease until they are stable on antiretroviral therapy for at least 1 year. Next slide, please. In terms of the prevalence of advanced HIV disease, a recent publication by the IDEA Collaboration reported that advanced HIV disease has persistently affected about 30% of people initiating ART in clinical programs since 2015, despite the scale-up of antiretroviral therapy. The graph shown on this slide summarizes data on the percentage of people living with HIV with advanced HIV disease at different stages of the HIV testing and treatment cascade from population-based HIV surveys conducted between 2015 and 2021 in 13 sub-Saharan African countries, with data for males shown in blue and females shown in orange. AHD prevalence differed across the cascade, affecting 15.4% of those unaware of their HIV status, 20.9% of those aware of their status but not on treatment, 29.5% of those on ART with an unsuppressed viral load, and 4.3% of those on ART and virally suppressed, with higher rates in males than in females. So taken together, these analyses demonstrate that advanced HIV disease is especially common not only in people presenting for ART initiation, but also those who are on treatment but are not virally suppressed. Next slide. Now, as Jessica mentioned, people with advanced HIV disease are at high risk of death, even after starting treatment, and this risk increases with decreasing CD4 cell count. The most common causes of severe illness and death in AHD include tuberculosis, severe bacterial infections, and cryptococcal disease. To reduce morbidity and mortality, the WHO recommends a package of interventions, which includes screening, treatment, and prophylaxis for major opportunistic infections, rapid initiation of antiretroviral therapy, and intensified adherence support. And now, Suzue, I'll turn it back to you.
Thank you. The objective of the assessment that the results we're showing today was to assess the progress in ICAP-supported programs to scale AHD services, including screening and diagnostics, case management and treatment, and availability of critical supplies and medications. We also hope to describe the AHD care cascade using aggregate data from screening, diagnosis, and treatment to determine any success and challenges. ICAP has been using its Program and Facilities Characteristics Tracking System, or PFACS, to assess rollout of different services in care and treatment and laboratory programs since 2007. In FY 2024, ICAP developed a new Advanced HIV Disease PFACS to assess the implementation of AHD services across ICAP-supported countries. The AHD PFACS assessment captures the availability of nationally recommended AHD screening, diagnostic, and management services to support people living with HIV with advanced HIV disease at the facility level to understand the extent of AHD services being provided. The assessment additionally evaluated the AHD care cascade using aggregate facility level data. The assessment was administered via Qualtrics by ICAP country staff, and the assessment was launched in July 2024, and the data collection was completed by September of 2024. The assessment covered 1,199 facilities across 14 countries. Here's the map of 1,199 facilities across 14 countries and 3 regions of the world that participated in the assessment. Most of the countries and facilities that contributed data are from Sub-Saharan Africa, as you can see from the darker shades of blue. And however, we did receive data from countries and facilities from Central Asia and the Philippines as well. So I'll start us off by characterizing the facilities participating in the assessment. Here we see the slide. This slide shows the distribution of facilities types by country. The assessment was completed by public primary in blue, public secondary in yellow, public tertiary in green, private in red, and other types of facilities in purple. Other includes clinics like workplace clinics and VIP clinics and the like. Overall, the vast majority of facilities contributing data were from 72% were public facilities, most of them primary level, and 19% were private facilities. Burundi, here in the second column, DRC, Nigeria, and the Philippines, there were a substantial number of private facilities contributing data. Whereas in Mozambique, for example, it's largely public primary facilities, as well as Kyrgyzstan, Tajikistan, Tanzania, Zambia. This slide shows the distribution of the location of the health facilities participating in the assessment. Urban city in blue, semi-urban noted in yellow, and rural is noted in green. The majority of facilities that contributed data here were rural, 52%, but Angola, here in the first column, DRC, the Philippines, had substantial number of facilities in urban cities as well. This graph shows the proportion of health facilities implementing national AHD packages of services for adults, and the next slide shows the data for children. Blue indicates implementation of AHD package of services, and yellow indicates no implementation. The majority, as you can see, the majority of the facilities do provide AHD services, except in Angola, Burundi, and the Philippines, where at the time of the assessment, facilities were not providing national AHD package of service. The picture was the same for AHD services for children, except in Central Asia, where programs did not support pediatric programming at the time of the assessment. So I'll hand this over back to Andrea to walk us through for results.
Thanks, Azue. So this slide shows the proportion of ICAP-supported health facilities that routinely use CD4 testing to assess recipients of care, whether or not they implement an AHD package. So as you can see, in DRC, Kazakhstan, Nigeria, and Zambia, the majority of supported sites have access to CD4 testing on site, either through point-of-care testing, shown in blue, or lab-based testing, shown in yellow. While most sites in Kyrgyzstan, Mozambique, and Tanzania rely on specimen referral, shown in red. In contrast, most supported sites in Tajikistan, and to a lesser extent, sites in the Philippines and Kyrgyzstan rely on patient referral for testing, shown in purple. And most supported sites in Angola, Cameroon, and South Sudan, as well as all of the sites in Burundi, do not have access to CD4 testing, shown in green. Next slide. The next series of slides show the proportion of health facilities that routinely provide CD4 testing to various priority populations that have a high prevalence of advanced HIV disease, including those initiating ART, those returning to care after treatment interruption, those with virological failure, and those who are seriously ill. Here we see the proportion of facilities that routinely provide CD4 testing to people newly enrolled on ART. And we see this proportion is similar to the proportion of health facilities using CD4 testing routinely that was shown in the prior slide, with the exception of Ethiopia and Kyrgyzstan, where CD4 testing for this population is limited to a subset of sites. Next slide. This slide shows the proportion of supported facilities routinely providing CD4 testing to people returning to treatment 1 year after interrupting treatment. Compared to enrollment in treatment, CD4 testing is provided to people returning to treatment at a lower proportion of health facilities in DRC and the Philippines, and a greater proportion in Kyrgyzstan. Next slide. In terms of routine provision of CD4 testing to people with virological failure, we see similar patterns as with returning to treatment, except in Kazakhstan, Kyrgyzstan, and the Philippines, where no sites provide CD4 testing for this population. Next slide. And for people who are seriously ill, there are some variations, most notably in Kazakhstan and the Philippines, with an increase in the proportion of sites routinely providing CD4 testing compared to people with virological failure. Next slide. This slide shows the proportion of health facilities using CD4 testing, shown in blue, WHO staging, shown in yellow, or both, shown in green, to identify people with advanced HIV disease. Most sites use both modalities, while many sites in Angola, Burundi, Cameroon, Ethiopia, Mozambique, and South Sudan rely on WHO staging exclusively. Next slide. So in the next two slides, we depict patient-level data as opposed to facility-level data. And this slide shows the age distribution of recipients of care diagnosed with advanced HIV disease based on CD4 testing. And the data are from the most recent quarter with available data in fiscal year 24. As shown in the graph, the majority of people with advanced HIV disease based on CD4 count were adults aged 20 and above, shown in green, with a substantial minority of children and adolescents with AHD, shown in blue and yellow, respectively, diagnosed based on CD4 count in South Sudan. Notably, no recipients of care were diagnosed with AHD based on CD4 in Cameroon. Next slide. Here we see the age distribution of recipients of care diagnosed with AHD based on WHO staging during the same time period. Here we see a number of people diagnosed with AHD in Cameroon and more representation of children and adolescents in blue and yellow, respectively, in Angola, Cameroon, DRC, and Mozambique. Note, no data were reported for Burundi. Next slide. Moving back to facility level data, this slide shows the proportion of health facilities using expert to diagnose TB, with availability of on-site testing in blue, off-site testing in yellow, and no testing available shown in green. In most African countries, as well as in Kyrgyzstan and the Philippines, there is a mix of sites with on and off-site testing, while in Kazakhstan and Tajikistan, there is off-site testing only. However, the majority of sites in Angola and a substantial minority of sites in Cameroon, DRC, and South Sudan do not have access to expert testing. Next slide. This slide shows the proportion of health facilities using the TB-LAM rapid test to diagnose TB. TB-LAM is available on-site, shown in blue, at some sites in Cameroon, DRC, Ethiopia, Mozambique, Nigeria, South Sudan, and Zambia, and in some sites by referral only, shown in yellow, particularly in Cameroon and DRC. However, TB-LAM is not available, shown in green, in Angola, Burundi, Kazakhstan, Kyrgyzstan, Tajikistan, and the Philippines. Next slide. This slide shows the proportion of facilities that use cryptococcal antigen test to screen for cryptococcal antigenemia in people with advanced HIV disease. Cryptococcal antigen testing is available either on-site, shown in blue, or off-site, shown in yellow, at the majority of sites in Tanzania and Zambia, a substantial proportion of sites in Nigeria and DRC, and a few sites in Cameroon, Ethiopia, and Mozambique, with no cryptococcal antigen testing available in Angola, Burundi, Kazakhstan, Kyrgyzstan, the Philippines, South Sudan, and Tajikistan. And now I will turn it over to Thais for data on Mozambique.
Hello, good morning and good afternoon, everyone. So my name is Thais, and I will present the TB cascade for Mozambique. So as you can see here, this slide presents the TB cascade and covers Q1 to Q3 of the 2024 fiscal year. And this is disaggregated by age groups. So under 10s, 10s to 19, and over 20. On the left, you can see a summary table and a bar chart showing the screening, diagnosis, and treatment initiation. On the left, we see a summary table and a bar chart, but I will explain on the right-hand side, the large bar. Please, if you can take a look, we will highlight the overall TB cascade for Mozambique for the same period, so covering from Q1 to Q3. So we have a total of 1,372 people with advanced HIV disease, and out of these, 90, so 50% were screened for TB using either TB-LAN or GeneXpert. And of those screened, 163 were diagnosed with TB, with a total of 100 clients initiation treatment. So this represents 92 treatment initiation rate among those that were diagnosed. There are some challenges in Mozambique and some contextual things that I think it's important to bring to understand a little bit about the existing gaps we faced during this time period. Stockouts of TB-LAM tests, which directly impact the ability to screen those eligible clients. We do also have missed opportunities, and this is related to the workflow and the workload that the current providers faces here in country. And there is one also challenge that is important to note is regarding privacy, because as we know, we need appropriate infrastructure to perform the TB-LAN testing. The test requires that the client provide a urine sample, and facilities have to ensure this privacy, which is not always the case. We had to support, for example, in one of the health facilities to conduct minor improvements and ensure that we have this in place. Other point that's important, we can see, despite of having a very few number of children screened, adolescents between 10 to 19, we see that in absolute numbers, those that are diagnosed were 4, which means that we have a lot of to work on this specific age. We know that is a challenge. Next slide, please. So in this slide, we will talk about the cryptococcal meningitis cascade for Mozambique covering the same period. So from Q1 to Q3. As on the left side, we have the table that is summarizing the number of clients with HTD and those that were screened, diagnosed, and those that were treated. On the right-hand side, this larger chart highlights the cascade across the supported health facilities here in Mozambique. So a total of 1,259 people with HTD, with advanced HIV disease. And we have around 24% of these screened for Cryptococcus meningitis. Among those screened, we see that just one was diagnosed with cryptococcal infections and no clients initiated treatment. So as we know, for clients who test positive on crack tests, it requires a lumbar puncture for confirmatory diagnosis. And we know that this also, we recognize that staff training, necessary supplies and equipment and referral systems, it's a challenge because, again, we have to ensure that we have appropriate space and appropriate conditions to conduct. And we face also the overload of activities for the same providers that are offering the service in the supported health facilities. So now I will hand to Tafadzua to share about Zambia. Thank you.
Thank you so much, Thais. My name is Tafadzwa Zina Marira, Country Director for ICAP in Zambia. I'll speak a bit about the same cascades for TB and cryptococcal meningitis, just to shed a bit more light on the Zambia findings. So our data is also presented in the same format with the tables and bar charts and following the similar cascade. So I will not describe that as well. So what we saw in Zambia was for the TB cascade, we had a total of 355 recipients of care that were diagnosed with AHD, and of those, 327 were screened, giving us a 92% screening coverage. And of those screened, 125 were diagnosed with TB, and of the 125, 121 received treatment, reflecting a 97% treatment coverage. And just to provide some additional context on these, on the screening rate. So what we saw was early in the year, which is FY24, we had severe stockouts of TB lamb across many facilities, and this negatively affected screening coverage. And we also saw delayed TB initiation at the time of collecting the data. Some patients were still being recalled at several sites to be initiated on treatment at the time where we were collecting the data. Moving on to cryptococcal meningitis. So we had 350 recipients of care with AHD, and of these, 246 were screened with the crack test, cryptococcal antigen test. And of those screened, 12 were diagnosed to be having cryptococcal meningitis. Of the 12 that were diagnosed, 11 were initiated on treatment. Again, similar to TB, we had inconsistency in availability of the cryptococcal antigen test throughout the course of the year. And what we also saw, which was affecting screening numbers, was there was delayed implementation of reflexive crack testing. Reflexive crack testing refers to when laboratories automatically process a blood sample for cryptococcal antigen screening once they have identified a low CD4 count without having to wait for the provider to the clinician to request one. So there was really delayed implementation of reflexive crack testing and also some variability in its implementation across sites. Also noteworthy is of the 12 that were diagnosed with cryptococcal meningitis, one of the recipients of care died. So that explains the 11 that were initiated on treatment. We had one case of death before treatment could be initiated. Thank you, and over to you, Suzoe.
Thank you, Taisha, and thank you to Fazwa for walking us through those data. So now we turn to commodities and medication availability. Here we see the proportion of facilities experiencing stockouts. I mean, we heard some from Fazwa and Taish for key commodities necessary to provide AHD services in the quarter prior to the assessment. So that was April to June of 2024. Stockouts are indicated in blue, while yellow indicates no stockouts, and gray indicates missing data. Stockouts were reported in all but one country. Kazakhstan did not report stockouts. Majority of facilities in DRC, Ethiopia, Kyrgyzstan, and Tajikistan reported stockouts of AHD commodities. So this slide examines the type of commodities that were experiencing stockouts during the April-June of 2024 period. As you can see, there were substantial stockouts involving CD4 reagents, shown in red, involving DRC, Ethiopia, Kyrgyzstan, Mozambique, Nigeria, South Sudan, and Zambia. Additionally, stockouts for TB screening and diagnostic commodities for expert and TB lamb in light and dark blue were reported by Burundi, DRC, Ethiopia, Mozambique, Nigeria, South Sudan, and Zambia. And finally, clotrimazole stockouts in purple were reported by Angola, Cameroon, Kyrgyzstan, Mozambique, South Sudan, Tajikistan, and Zambia. And TBT stockouts, so stockouts in yellow by Angola, Cameroon, Nigeria, South Sudan, and Tanzania and Zambia. So before we conclude, we have a few slides to show the availability of medications for cryptococcal meningitis treatment. This slide shows the proportion of facilities where liposomal amphotericin B, a preferred drug for CM induction therapy, along with flucidazine and fluconazole. Liposomal ampho B is preferred over ampho B for CM induction therapy due to better tolerability. But as you can see, very few facilities and countries reported having this drug. A significant minority of facilities, from only 7 out of the 14 countries, reporting having this medication. If liposomal amphotericin is not available, amphotericin B can be used with flucidazine and fluconazole for treatment of CM. The picture is really the same as the previous slide. Very limited availability of amphotericin B across the 7 countries reporting data. Availability of fluconazole is better. All 14 countries reported having availability, and majority of facilities in 10 out of the 14 countries reported having availability of fluconazole. This is likely due to its use also as primary prophylaxis for cryptococcal antigenemia and oral thrush. Finally, availability of flucidazine shown in this is shown in this graph. The availability is limited to 8 out of the 14 countries and a significant minority of facilities in those countries. So here we summarize our results. We believe this is one of the first assessments of service availability of advanced HIV disease globally, covering over 1,000 facilities across 14 countries in 3 different regions of the world. CD4 testing services were available on or off-site in most ICAP-supported facilities, except in Angola, Burundi, Cameroon, and South Sudan. However, some sites used WHO staging exclusively for diagnosis of AHD, and we know that that may miss a substantial number of recipients of care with AHD. Majority of facilities refer samples for CD4 testing off-site, which potentially can delay AHD diagnosis, leading to poorer outcomes. CD4 testing services are most commonly provided to those newly initiating on ART, and other priority populations have less access. TB-LAM has not been widely adopted across countries and facilities despite its lower cost. And Thais spoke about some limitations. Stockouts of AHD commodities are common across most countries, and access to screening and treatment for cryptococcal disease is severely limited in the facilities covered in this assessment. So to conclude, the assessment results serve as an important baseline to assess further progress and expansion of advanced HIV disease services in the years to come, and continued investment in the scale-up of AHD services from both domestic and international funding sources will be very important. And AHD services are really critical to improve health outcomes in people living with HIV and to continue driving down the mortality among people living with HIV globally. So I wanted to thank Hei Liu, Aisha for the analysis and slide preparation, other staff from the clinical laboratory and SI units, as well as the sequence staff for contributing, working on the questionnaire development. Of course, the ICAP country offices who work to collect the data, collaborating with the health facility staff that we support, and people living with HIV, as well as our donor who support most of our country programs. Thank you. And we can take some questions.
Okay, that's really a wonderful talk, everybody. It was, I think, very comprehensive and very clear. We have questions, I think, that kind of go in, well, at least 2 directions. Some questions really want clarifications about the data that you've presented about what was happening during 2024. And there are a few questions interested in people's thoughts projecting forward. I think certainly let's start with the questions about the data that was presented already. So let me first lay out a question about any thoughts concerning people living with HIV who have advanced HIV disease and have persistent low-level viremia. I guess I don't believe that this facility survey really focused in on that, and that might be the answer, but let's start with that question.
Hi, Jessica, it's Andrea, and yes, you're right. This survey did not focus on those individuals at all. And you know, most data I've seen about sort of advanced HIV disease, when they're talking about, I mean, it's, as you know, the definition is based on CD4 count and not viral load. And it's really when people have virological failure that the prevalence of advanced HIV disease is high. I mean, certainly if someone has persistent low level viremia, you worry that they are developing treatment failure, but it's really people that have treatment failure that are going to have a high prevalence of AHD.
Right. And you mentioned that in your overview at the beginning with the data from the FIA surveys, talking about I think it was 29% of those individuals with unsuppressed viral load who were on ART had advanced HIV disease. So maybe the best thing to do is take a closer look at that paper. There's a question specifically for Zambia, asking how has Zambia maintained such high levels of cryptococcal meningitis treatment coverage, considering that capacity may not be available at all levels of care. So perhaps, Tafadzwa, you'd like to take that one on and talk about how Zambia has been managing. Thank you.
Thank you, Jessica. So as part of ICAP's TA role to the Western Province, so this sample facilities was from the Western Province of Zambia, where ICAP works to provide technical assistance. So as part of our TA role, we have been heavily involved in training healthcare workers on management of cryptococcal meningitis, and basically all TB, cryptococcal meningitis, advanced HIV in general. So that contributed to having the skills available at sites. We're building capacity of healthcare workers working for those facilities. And we've also been actively involved in the supply chain component for the provinces that we are providing technical assistance, working with the national supply chain, ZAMSA, to make sure that drugs are available at the sites where we are supporting, to make sure that quantification is being done properly, and providing logistical support where needed to redistribute commodities. We've also been supporting that. So I think those have contributed to the high coverage that we saw from this survey.
Great. Andrea, anything to add or?
No, I think that's a very comprehensive answer. I think that the Zambia experience demonstrates that it's feasible to diagnose and treat cryptococcal meningitis in these settings. And I think some of these lessons learned, can be applied elsewhere. Certainly the technical assistance ICAP provided has been helpful in building capacity in that setting.
Right. I think there's a question looking for some clarification about how the survey assessed access to CD4 testing and whether it allowed for countries that reported stockouts of reagents and supplies. Suzue, I see you nodding your head.
Yeah, I was typing an answer. So we collected both things. The capacity. So if they had capacity, the CD4 machine and a regular sort of supply chain to replenish reagents, it was access. And then they were able to report if they had stock out in the quarter before the assessment. So we captured both things. And I think we presented both things. Jessica, are you there?
I was muted. I'm trying to still focus more on our questions about clarifying the data that was already presented. Let's see. Give me a second. Sorry. All right, we already have clarification about ICAP-supported facilities, and about flucytosine.
I mean, I can comment on the ICAP supported. There
Yeah.
might be more additional.
Yeah.
So just to clarify, these were PEPFAR funded ICAP supported facilities across the 14 countries. The level of support varies by country. Some countries offer technical assistance, so above site support. In other countries, it is more direct service delivery support with staffing support at facilities, so it does vary. We did not make that distinction in our presentation, but we could. Thank you.
Sure. Right. I think we could also just think about, and perhaps it's maybe, well, this could be a question for any of our panelists to comment on, the higher prevalence of advanced HIV disease among men compared to women, and what that means for our programs. Again, I don't know if, well, there was some data that disaggregated by sex. So we could think about, you know, if you have any clarifications on that. Yeah, go ahead.
Yeah, hi, Jessica. So I can start. So the data we showed that was disaggregated by sex was the FIA data rather than ICAP data. And we saw sort of higher levels of AHD across the testing and treatment cascade in those FIA data. And so I think this is sort of aligns with what we know and sort of like delayed presentation and less engagement with health services among males in many of these settings. And I don't know if either of our colleagues from country programs can speak more specifically about their context. Over.
Aisha or Tapato, any further comments?
Hi, it's Safalzo. I think Andrea covered it well. It's a similar pattern that we see with even testing. You would find that men would delay to get a test done, as well as subsequently, delayed treatment initiation. And then also we see lower engagement in care among men. I think when we looked at some data for interruption in treatment, we also saw some similar patterns reflecting some challenges to do with lower engagement in care among men as well. Thank you.
So maybe that I should just add that, there have been a lot of efforts over the past few years to try to differentiate services for men and other populations that have had challenges with accessing services. And I think it's important to note that at least for our survey, it was cross-section, one period in time. Although the FIA data obviously spans several years. But there have been efforts to sort of address these barriers to testing and treatment.
Great. I think another point perhaps that I think is implicit in the data, but not exactly spelled out, is AHD is not just about treatment. I think we also want to think about ways to prevent it. And that means, repeat testing for certain populations and ensuring, timely initiation of ART and maintenance of viral suppression. Now, I don't think that in our survey, there was as much of a focus on prevention of AHD. Any comments or thoughts on that point?
I mean, you're exactly right. It wasn't the focus of the presentation or of this survey, but I mean, as you mentioned, repeat testing for populations at an increased risk of HIV acquisition is important to identify people with HIV early, to engaging them in treatment to prevent sort of the development of advanced disease. And I think also very importantly, to have sort of high quality person-centered services to ensure continued engagement in HIV treatment, because we realize that sort of that cycle or churn of disengagement and re-engagement is really an important sort of risk factor for developing advanced HIV disease. So it's another effort and focus of HIV programming. Over.
Great. So maybe now we will try and turn to the more difficult task of predicting the future. I am fond of the statement that predicting the future is a hazardous occupation. But I think first, starting with the data that we have, any sort of big picture thoughts on what at least what were the biggest challenges last year facing individuals living with advanced HIV disease from a clinical perspective? Any comments on what those challenges were from the data that we have? Big picture.
Tafaza or Thais, did you want to go first? Just specifically for Mozambique and Zambia? And then I can add something. Thais, why don't you go first?
So I think, as you probably all are aware, we still have challenge because all the system, sorry, I'm trying to open my video. It's manually, it's paper-based, and most of the time we have just few providers that are supporting some of the times more than one entry point. So it's the same MCH nurse that is seeing a client in the family planning, but as well in the MCH. So that is on the reality, it becomes a challenge because it's this all the same provider who is collecting data from during the consultation, have to fill a lot of registers forms. And we know that all of this process is taking not only time, but we have to aggregate the data. There is a lot of support on reviewing these and ensuring that this registers and all of this informations are well recorded and registered. And by the end of the week, by the end of the month, this is surely the part of the ICAP support on this literacy, I would say, just to ensure that we have this in place and we can collect, analyze, review, and clean the data on a weekly basis, discuss this. But we do have those challenges that are related to the lack of number of healthcare workers, the large number of register that is related, because it's not only that we one register, but different registers to collect information for the HIV in general, including the advanced HIV disease. And as you see when Suzu was explaining, we have like on-site, CD4 on-site, some are referral, so there is a lot of back and forth that we must have to accompany, to review and support to ensure that we have the health facility has all of the information in place. Thank you.
Tafaza, anything to add?
Thank you, Suzwe. So I'll just quickly add CD4 testing as well. That was one major challenge, access and availability to CD4 testing that we continue to see, at least for these ICAP-supported sites. We were coming in as partners to support sample transportation from sites that would not be having access to a point of care machine to other sites that would be offering the testing. So I think that also was a major challenge in addition to the supply chain that we've covered extensively throughout the talk today.
Right. So certainly many challenges just from the period of time we are looking at the data on. Does anybody want to take a stab at predicting what is coming? I mean, I guess I will say there's a very important caveat that it's still not clear, you know, even at sort of important levels, understanding, you know, how much external funding countries are going to have. And so I do think it makes it quite difficult, if not hazardous, as I mentioned, to predict the future. But I think, you know, the past should inform our understanding of what may be coming. Any further thoughts from that point? Suzu?
No, I think that's right. I think, I mean, just looking at the data, I think diagnosis of AHD is very challenging. You know, CD4 is not accessible widely, and yeah, as you said, the funding for it is uncertain. I think there'll be a lot of need for domestic resources to complement. But yeah, diagnosis of AHD, as well as, you know, just like sort of persistent commodity shortages and medication shortages, does seem to be a challenge and will continue to be.
Great. Okay, I think we have time for one last question from Eugenie before we wrap up. Eugenie, please go ahead.
Sorry, I think I touched the wrong button, so I apologize for that. But maybe I might add that, you know, a lot of these results also complement some of the findings that we saw through our Burundi assessment of advanced HIV disease, in which, you know, we were able to conduct point of care Visitec CD4 testing to inform AHD management. And so I appreciated kind of the key summary points and takeaways that were raised that were really kind of aligned with what we also saw from our data.
Yeah, thanks, Eugenie. And I was going to mention that assessment as well. In addition to Burundi, in South Sudan, and I believe other ICAP programs, ICAP has worked with the ministry to pilot the use of Visitec, so a semi-quantitative rapid CD4 test to identify people with advanced HIV disease. And I do think that is a, you know, a potential solution to sort of this issue of like quickly identifying people with advanced HIV disease. Although clearly, you know, there'll need to be funding and good supply chain in order to realize that over.
Great. Well, thank you, everybody. I think this was a really marvelous webinar, and we certainly have had a very active Q&A and a lot of participants in our audience. Let me just mention that our next webinar will be August 19th at 9 a.m. And we will be talking about Marburg and beyond, a discussion about the threat of viral hemorrhagic fever. So please put that on your and be sure to join us then. Again, a reminder that the webinar recording and the slides will be posted on the ICAP website. Thank you all for joining us today.
Thank you.